Chapter 16, Processes and Stages of Labor and Birth. There are several factors that affect labor progress. The birth passageway is the birth canal, and the passenger is the fetus. The birth passage depends on the size of the pelvis, the fetal head size, and the presence of molding. It also depends on fetal attitude, which is the flexion or extension of the fetal body and extremities, and the fetal lie, and the fetal presentation, which is the part of the fetal body that's entering the pelvis first in either a single or a multiple gestation pregnancy. Relationship between the passageway and the fetus is related to the engagement of the fetal presenting part, the station or the location of the fetal presenting part within the maternal pelvis, and the fetal position, which is a relationship of the presenting part to one of the four quadrants of the maternal pelvis. Physiological forces of labor include frequency, duration, and intensity of uterine contractions as the fetus moves through the birth passageway, effectiveness of the maternal pushing effort, and duration of labor. Psychosocial considerations include physical preparation for childbirth, social-cultural values and beliefs, previous childbirth experiences, support from significant others, and emotional status. The true pelvis, which forms the bony canal through which the fetus must pass, is divided into three sections: the inlet, the pelvic cavity, or mid-pelvis, and the outlet. There are four types, and they're gynecoid, android, arthropoid, and palatoploid. The gynecoid and arthropoid shapes are both competent for vaginal deliveries. Two frontal bones, two parietal bones, and the occipital bone make up the fetal head. And you can see this in figure 16.2 in your book. These bones are not fused, so the portion of the head can adjust to the shape as the presenting part passes through the narrow portions of the pelvis. The cranial bones overlap under pressure of the powers of labor and the demands of the unyielding pelvis. The sutures of the fetal skull are membranous spaces between the cranial bones, which allow for molding. The anterior and posterior fontanelles are clinically useful, along with the sutures, in identifying the position of the fetal head in the pelvis and in assessing the status of the newborn after birth. The anterior fontanelle is diamond shaped. This is a view from the top or the superior part of the fetal skull. Vertex is the area between the anterior and posterior fontanelles. When we say a baby is vertex, we mean that the head is the presenting part, the vertex part of the head. The smallest diameter of the fetal head presents into the maternal pelvis with the vertex going first. It is the most common presentation, and the most common presentation of the vertex is the occiput. Fetal attitude is the tone of the baby, whether it's inflection and flexed forward, or whether it is extended and able to move his head into different positions. The relationship of the spinal column of the fetus to that of its mother is either going to be a longitudinal or transverse lie across or up and down with it. Engagement happens when the largest diameter of the presenting part, which is hopefully the head, passes through the pelvic inlet and is at the level of the ischial spines. And you can see on the diagram, this is your stations, with the dark line being 0 station. Remember that the fetal head is directed down toward the pelvis, but if it can still easily move away from the inlet, it is called floating. In this presentation, when the baby is still able to float or be blottable, the cord prolapse is a possibility if the membranes rupture. Dipping is the fetal head dips into the inlet but can be moved away by exerting pressure on the fetus. Engaged means the biparietal diameter of the fetal head is in the inlet of the pelvis. In most instances, the presenting part, which is the occiput, is at the level of the ischial spines, which is 0 station. That is engaged. The ischial spines mark the narrowed diameter through which the fetus must pass. So that is the smallest diameter where the fetus goes through. If the presenting part is higher than the ischial spines, a negative number is assigned, noting in centimeters above 0 station, which is -1 to -2 and on up. Positive numbers indicate that the presenting part has passed through or at the tightest spot between the ischial spines. The largest part of the baby's head is at the smallest part of the mom's pelvis. So as the plus numbers, +1, it's past that 0 station and has fit through that narrowed area. If the presenting part can be seen at the woman's perineum, birth is imminent. During labor, the presenting part should move progressively from the negative stations to the mid-pelvis at 0 station and into the positive stations. If the presenting part fails to descend in the presence of strong contractions, there may be disproportion between the maternal pelvis and the fetal presenting part. In this view, the station is -2 to -3, so it's still above those ischial spines. The landmark chosen for vertex presentations is the occiput, and the landmark for face presentations is the mentum. In breech presentations, the sacrum is the designated landmark, and the acromion process on the scapula is the landmark for shoulder presentations. Fetal occiput is directed toward the back and the left of the birth passageway, and that's abbreviated LOP, left occiput posterior. Most common fetal position is the occiput anterior. Primary and secondary forces work together. Primary force is uterine muscular contractions, which cause the complete effacement and dilation of the cervix. Secondary force is the use of abdominal muscles to push during the second stage of labor. Contractions has 3 phases: the increment, which is the building up of the contraction and the longest phase, the acme, or the peak of the contraction, and the decrement, or the letting up of the contraction. Frequency, duration, and intensity are used to describe uterine contractions during labor. By palpation, mild, moderate, or strong contractions. Strong contractions intensity exists when the uterine wall cannot be indented. Normal resting pressure is the uterus between contractions, and that averages at about 10 to 12 millimeters of mercury. During acme, or the peak of the contraction, The intensity ranges from 25 to 40 millimeters of mercury in early labor, 50 to 70 millimeters of mercury in active labor, and 70 to 90 millimeters of mercury during transition, 70 to 100 millimeters of mercury while the woman is pushing. After the cervix is completely dilated, the maternal abdominal muscles contract as the woman pushes. This pushing action is also called bearing down. If the cervix is not completely dilated, bearing down can cause cervical edema, which slows down dilation, possible tearing of the cervix, and bruising of the cervix, along with maternal exhaustion. Physiologic factors that affect labor are fears, anxieties that the mom may have going on, excitement level, feelings of joy and anticipation, and her level of support. A prima gravida, which is a first-time pregnancy, beginning of labor, there is no cervical effacement or dilation. The fetal head is cushioned by amniotic fluid. Beginning cervical effacement, as the cervix begins to efface, more amniotic fluid collects below the fetal head. The cervix is about 1/2 effaced and slightly dilated in this picture. The increasing amount of amniotic fluid exerts hydrostatic pressure. This is complete effacement and dilation. Lightning describes the effects that occur when the fetus begins to settle in the pelvic inlet or become engaged. It allows breathing to become easier for mom. Braxton Hicks contractions are usually irregular, intermittent contractions that have been occurring throughout the pregnancy, may become uncomfortable. At the beginning of pregnancy, the cervix is rigid and firm, and it must soften so it can stretch and dilate to allow for the fetal passage. This softening of the cervix is called ripening. Sudden burst of energy, approximately 24 to 48 hours before labor, is common in the pregnant woman. Early signs of labor include weight loss, indigestion, nausea, vomiting, diarrhea, bloody show, and maybe rupture of membranes. False labor or Braxton Hicks contractions usually is described as the baby balling up. There's a lack of cervical effacement and dilation with these types of contractions. They are usually irregular and do not increase in frequency, duration, and intensity. The contractions occur mainly in the lower abdomen and groin, and the pain may be relieved by ambulation, changes in position, resting, a hot bath, or shower. True labor, you will see progressive dilation and effacement of the cervix. Regular contractions will increase in frequency, duration, and intensity. The pain usually starts towards the back and radiates across around to the front of the abdomen, and pain is not normally relieved by ambulation or resting. First stage of labor includes 3 phases. The first phase is a latent phase. It starts with the beginning of regular contractions and increases in frequency, duration, and intensity. Mild contractions lasting 30 seconds with a frequency of about anywhere between 10 and 30 minutes apart, and progress to moderate contractions lasting 30 to 40 seconds apart with a frequency of about 5 to 7 minutes. Lasting 30 to 40 seconds, and then the frequency is about 5 to 7 minutes now. In the first time mom, the nullipara, the latent phase or early phase, averages about 8.6 hours, but should not exceed 20 hours. In the multiparous, it averages about 5.3 hours and should not exceed 14 hours. Spontaneous ruptured membranes generally occurs at the height of an intensive contraction with a gush of fluid out of the vagina. The membranes are ruptured by the physician or the healthcare provider using an instrument called the amnio hook. The procedure is called an amniotomy, or artificial rupture of membranes, AROM. Latent phase, if they request pain medicine in this phase, it can prolong labor. In the active phase, the mother feels a sense of purpose and need for regrouping. Helplessness and decreased coping ability may be present. Anxiety tends to increase as she senses the intensification of contractions and pain. Support persons' involvement may increase satisfaction and decrease anxiety. During this phase, the cervix dilates from about 4 to 7 centimeters. Fetal descent is progressive. Relaxation is important. Tension can slow labor, increase pain sensations, and fear. During transition, contractions have a frequency of about every 1.5 to 2 minutes, a duration of 60 to 90 seconds, and are strong in intensity. Cervical dilation slows as it progresses from 8 to 10 centimeters, and the rate of fetal descent dramatically increases. It does not usually last longer than 3 hours for nulliparous or longer than 1 hour for multiparous. As dilation approaches 10 centimeters, the woman may feel increased rectal pressure and an uncomfortable desire to bear down. The amount of bloody show may increase and the membranes may rupture. The nurse should reassure the woman that she will not be left alone, and it's important to be available as relief support for the support person. At this point, progressive dilation and in the transition phase, at this point, the mom may not want to be talked to or touched, but it'll be important for her to have her support person present continuously. Second stage of labor. In this stage, labor begins with the complete cervical dilation and ends with birth of the baby. The cardinal movements or mechanisms of labor are descent, internal rotation, external rotation, and extension. And this is when I showed you that it looks like the baby's head's being turned to the side, but the baby is actually turning itself and rotating back into position. This is when mom gets to push and normally feels better. Assessing the effectiveness of mom's pushing effort is important. Providing encouragement and direction to obtain a more adequate pushing effort. Assessing fetal response that occurs as maternal pushing is performed, including continual fetal assessment measures. What you will see physically toward end of the second stage of labor includes the perineum is bulging with head of the fetus, the labia separate, there will be crowning, and increased bloody show. After the baby is born, the uterus contracts its capacity and the surface area of the placental attachment. When the signs of placental separation appear, the woman may bear down to aid in placental expulsion. The fetal side is the shiny side and is normally presenting. A placenta is considered to be retained if it's 30 minutes or longer. After 30 minutes have elapsed from completion of the second stage of labor, it's considered to be retained. The fourth stage of labor is the time from 1 to 4 hours after birth, during which physiologic readjustment of the mother's body begins. Fundal checks will be needed every 15 minutes for the first hour, every 30 minutes for the second hour, or per policy of the healthcare facility. Fundal checks coincide with bleeding checks. Fundus should contract and be firm. It should be midline in the abdomen between the umbilicus and the symphysis pubis. It should be small to moderate bleeding or lochia. If the uterus is boggy and does not feel firm, it needs to be massaged until firm in order to stop and slow bleeding. If it is not midline in the abdomen, check the bladder and make sure it's not full. It needs to be emptied if so. A full bladder will keep bleeding, will have bleeding continue. Always assist during the initial attempt of the woman to ambulate, because dizziness and fainting can lead to severe falls. Make sure she empties her bladder right away, again to decrease bleeding and keep the fundus firm. Systemic responses to labor: increase in cardiac output of as much as 10 to 15% over the typical third trimester. And anxiety and pain from contractions increase, so hyperventilation frequently occurs. You may see mom become diaphoretic, and there's a change in acid and base balance. Systemic responses to labor: impaired blood and lymph drainage from the base of the bladder, reduced gastric mobility, increased white blood cells is normal in the delivered mom, 25 to 30,000, decreased maternal blood glucose, and pain. Adaptations of the fetus: you'll see fetal heart rate decelerations due to intracranial pressure, which is called head compression, and early decelerations. The newborn should be in a quiet and awake state, and they are aware of pressure sensations. Chapter 17, Intrapartum Nursing Assessment. When the woman presents intrapartumly into the healthcare setting, we need to obtain a brief oral history when she's being admitted to the birthing area. The attending physician or certified nurse midwife and pediatrician need to be notified that she is there. We need to confirm her last menstrual period with the estimated date of birth. We always check her gravidus, para, her number of abortions, number of living children, and stillbirths. Pregnancy data is very important. Medications: we need to know if she has a history of drug and alcohol use, if she smokes with her pregnancy, and if she has any allergies. The method chosen that she's chosen for newborn feeding, we need to know as well. The woman's preferences about her labor and birth, such as no episiotomy or no analgesics or anesthetics, or the presence of the father and others at the birth, it needs to be known and documented. If she has a birth plan, that is something that's really good to put on the chart so each healthcare provider who's caring for her can see. We'll need to get vital signs and weight. We always check lungs, make sure there's no problems. Her fundus needs to be checked for size. We need to check for contractions and palpate the strength. of those contractions. Look for edema, not just in the feet and legs, but in the hands and face. Her hydration status should be assessed, and her perineum should be assessed, such as a cervical check for dilation and effacement. Labor status, assess contractions for frequency, duration, and intensity by again palpating on the uterine fundus. We also need to palpate the relaxation between contractions. Cervical dilation and effacement are evaluated directly by a vaginal examination. The vaginal examination can also provide information about membrane status, if she's ruptured or not, characteristics of the amniotic fluid, if it is, fetal position, and fetal station. Onset of labor, we need to know when that happened and the status of the amniotic membranes as far as the woman knows. Are they intact or ruptured? And the time that they did rupture, if that's what she reports, along with the color of the fluid and the odor that she may have noticed. Amniotic fluid should be pretty clear and odorless. In the prime emperor, at least 1.2 centimeters per hour for dilation is normal. At least 1 centimeter per hour on descent of the fetus, and less than 2 hours in the second stage or pushing stage. For the multipara, at least 1.5 centimeters per hour for dilation, at least 2.1 centimeters per hour for descent of the fetus, and less than 1 hour in the second stage. Remember, fetal heart tones should always be evaluated before any procedure or medications. If for some reason you have a patient on a fetal monitor and they end up having to come off to go to the operating room for a cesarean section, we always listen to fetal heart tones right before they actually start the surgery. When we're evaluating the fetal heart, we're also looking for activity, movement. A mom can report that, and a lot of times you can see it on the monitor as well. We need to know the presentation and the position of the fetus. This slide shows you different positions that the fetus can be in, and we discussed this earlier. They can be right occiput anterior or left occiput anterior. You can check this by the sutures and fontanelles, which way they're facing. If they're posterior, which is OP, occiput posterior, a good way to help the baby change that position is by having mom get on her hands and knees. This is external fetal monitoring. It's a continuous recording. It's placed on the toco is placed on the uterine fundus, and it records uterine contractions. It will record the frequency and the duration of the contractions, but not the strength of the contractions nor the resting tone in between. The lower belt holds the ultrasonic device that monitors the fetal heart rate. Remember, we checked the baseline of the fetal heart rate, and that is not associated with any accelerations or decelerations that the baby may have. These are internal fetal monitors. They are used to better monitor contractions or the fetal heart tones. Internal fetal monitors are necessary when the baby is having decelerations or there is meconium amniotic fluid, or if you just are unable to pick up the baby externally, they may be indicated. Again, remember when the membranes are ruptured, we want to limit vaginal examinations as much as possible due to there is now an opportunity for infection to arise. This is the fetal scalp electrode internal. Values and beliefs, support person and the father. We need to know practices and preferences of the pregnant woman and the father as well. So we want to give them as much choice and control as we can. Allow them to pick who they want in the labor room, what to wear if possible, what position they prefer for birth, the temperature of the fluids that they want to drink. They may want cold or they may want warm, and always provide privacy. Psychosocial assessment, preparation for childbirth. We need to know what their fears or anxieties might be related to childbirth, their excitement level, and their social support. Psychosocially, again, birth goals or fantasies need to be discussed. Hopefully we're going to be seeing feelings of joy and anticipation, but sometimes fear and anxiety get in the way of that. They may fear having a bowel movement during the second stage of labor, which is a very common fear for a woman. They need reassurance. Some women may come in feeling a sense of failure if they want to have an unmedicated birth and then they decide to use pain medication. We want to again support the mom with their decisions and be sure to encourage mom to always be flexible depending on her needs and baby's needs. Advantages to palpating. It is non-invasive. It's easy to do. That increases one-on-one care with your patient. And it allows mom to be up and down much easier. Disadvantages includes it doesn't give us an actual measure of uterine pressure. There's no permanent record. And maternal size and positioning may prevent us from direct palpation. The latent phase of labor, contractions are about every 10 to 30 minutes, lasting about 30 to 40 seconds, and are usually mild. This progresses to contractions every 5 to 7 minutes, lasting 30 to 40 seconds, and become more moderate to palpation. The active phase of labor, contractions are about 2 to 5 minutes apart, lasting 40 to 60 seconds. They are usually moderate to strong contractions. Transition phase, every 1.5 to 2 minutes. The contractions are lasting from 60 to 90 seconds and usually palpate strong or register strong with an internal monitor. The electronic monitor for uterine contractions provides continuous data. It's routine in some settings, some healthcare facilities. It's used for high-risk patients and women who are getting oxytocin to induce labor. It must be combined with careful nursing assessment. This is the internal pressure monitor catheter we were discussing in lab. The vaginal examination, when we're doing that, or the physician's doing that, they're looking for cervical effacement and dilation. They're checking the fetal station and they're checking to make sure we know what the presenting part is. This is Leopold's maneuver. It's to determine fetal position and presentation. This is done by palpating the abdomen with both hands in different sections to determine if the baby's head down or breech. Inspection of the woman's abdomen and palpation of the woman's abdomen along with vaginal examination helps to determine presenting part. An ultrasound can be done to confirm the presenting part, and we need to auscultate the fetal heart rate as well while this is happening. Auscultation is done either intermittently or continuously. It can be done with a Doppler. It's a handheld device for listening to fetal heart tones. Auscultate the fetal heart rate both between, during, and immediately after uterine contractions. That's the only way you'll be able to hear if they're having decelerations, especially late decelerations. Leopold's maneuver to help find the fetal heart rate. And you want to count for at least 30 seconds and multiply by 2 when you do get that heart tones. In low-risk women, the frequency of listening to the fetal heart tones is about every 30 minutes in early or first stage and every 15 minutes in the second stage. This can be different relating to the healthcare facility. Frequency in high-risk women is more often, every 15 minutes during the first stage and every 5 minutes during the second stage. You may find that more frequent is preferable. We need to know the baseline fetal heart rate for the fetus, and the normal is between 110 and 160 beats per minute. The fetal baseline is determined by looking at the strip, and it does not include any accelerations or decelerations. The fetal heart rate should be traced for a 10-minute period, and we need to observe it for at least 2 minutes while it's going on. Here's your normal fetal heart tones. Tachycardia if it's over 160. Marked tachycardia if it's 180 beats or higher. And bradycardia if it's less than 110 beats per minute. So evaluation of uterine contractions. Be sure and assess uterine contraction pattern. Look at the resting tone, how well the uterus relaxes in between, especially when they're on oxytocin or pitocin. We need to know the frequency, duration, and intensity of these contractions. Variability should be present in the fetal heart rate. That's the little ups and downs, the beat to beat changes in the heart rate, and it should be in the moderate range or average. There should be no variable or late decelerations present with a baby who has good well-being. Accelerations should be present. They may be absent during fetal sleep. Early decelerations may be present in the fetus, and that's still okay. Early decelerations are due to head compression, and that is sometimes the sign of ending labor. And no specific action is required for any of these that we see here. So this strip shows you the difference in variability. That's the beat to beat heart rate changes and the baselines. The first strip on the top left shows you marked variability or average. The second strip, B, is moderate variability. C shows minimal variability, and D is absent variability. Accelerations are the transient increases in the fetal heart rate normally caused by fetal movement, and you can see those in the first strip. Decelerations are periodic decreases in the fetal heart rate from the normal baseline. They are categorized as early, late, and variable according to the time of their occurrence in the contraction cycle. Reduced variability is the best single predictor for determining fetal compromise. Marked variability, again, the amplitude is greater than 25 beats per minute. From one beat to the next, you're going to see a difference of 25 beats. Moderate, 6 to 25. Minimal, it's detectable, but it may be 5 beats per minute or less. And then absent, it's not detectable. Hypoxia and acidosis is a decreased blood flow to the fetus. Administration of drugs such as Demerol and Valium, diazepam, or hydroxyzine, Vistaril, depresses the fetal central nervous system and can cause this decrease in variability. Fetal sleep cycle, during sleep, the variability will be decreased, and that usually lasts about 20 to 40 minutes each hour. The fetus of less than 32 weeks gestation has a immature neurological control of its heart rate. So therefore, you're not going to see a lot of variability in a fetus that early, that young. Fetal anomalies that affect the heart or the central nervous system or the autonomic nervous system can affect the variability. Fetal dysrhythmias, again, affecting the heart, central nervous system, and autonomic nervous system. And previous neurological insults, such as tachycardia, can affect variability. Causes of marked variability include early mild hypoxia, fetal stimulation or activity from maybe a maternal vaginal exam can cause an increase in variability. Putting on a fetal scalp electrode can also cause the baby's heart rate to differ and increase the variability. Advancing gestational age, greater than 30 weeks gestation, and medications that are stimulants can all affect variability of the fetus. Absent variability that does not appear to be associated with the fetal sleep cycle or the administration of drugs is a warning sign of a non-reassuring fetal status. It's especially ominous if absent or minimal variability is accompanied by late decelerations. The normal fetal heart rate on this strip, it's about in the 140s to 158 beats per minute. This has a presence of a long and a short-term variability, an absence of decelerations with adequate contractions. So this is a reassuring fetal heart strip and contraction pattern. The contractions are about every 2.5 minutes, duration lasting 50 to 60 seconds. So this is a reassuring strip. This is another strip of a fetus with several accelerations and fetal movements, a good contraction pattern, and shows positive fetal well-being. Head compression is the cause of early decelerations, and these are early decelerations. They mirror the contraction. They start and stop at the same time that the contraction does. Earlies, again, are head compression and does not require any intervention. Refer to your book and see Table 17.5 to describe this information. A category 2, which is an indeterminate, a fetus would show a baseline that includes bradycardia with continued variability or tachycardia, baseline changes in variability, no accelerations, even with scalp stimulation. That's when you do a vaginal check and kind of rub their head a little bit and stimulate their scalp, hoping to elicit a acceleration, and that fails. Episodic decelerations, variable decelerations. This requires some more evaluation, continued surveillance, and maybe some more reevaluation. So if they're having occasional variable decels, then that may be cord compression. Sometimes changing positions will help correct these problems. Checking the temperature for fetal tachycardia is important to assess for infection and fever. This again is your category 2. And this is a category 2 strip. This contraction pattern is okay. It's not too close. It doesn't look like. This baby has some accelerations, but it also has the big variable decel, which is shaped like a V or a W. And then it has a small one a little bit later. This is cord compression. Oftentimes, getting the baby off the cord by changing mom's positions will help correct this. Category 3, this is an abnormal tracing. In this category, we'll have absent variability in the baseline fetal heart rate. You're going to have recurrent late decelerations, recurrent variable decelerations, and or bradycardia. You may see a sinusoidal fetal heart rate pattern. Category 3 tracings require immediate attention, and it may indicate the need for delivery the fastest route, which may be a cesarean section. So this is when you do need to do something about it. It may start with position changes, turning Pitocin off if it's being administered, putting oxygen on the mom at 7 to 10 liters per minute via a face mask, and increasing fluids. Always let your doctor know this is going on immediately. This is a non-reassuring fetal heart tracing, and you can see it's having late decelerations, which start at the peak of the contraction and they end well after the contraction has ended. The variable decel is the first one that you see, kind of the WV shaped, and then the lates are the next two after the contractions. The fetal heart rate shows no variability in between those decelerations. Tachycardia can be a sign that there's a problem, especially if it's associated with late decelerations or severe variable decelerations, and also with decreased variability. It can be associated with maternal fever. Treatment may just include Tylenol or antipyretics and or antibiotics. Bradycardia in the fetus, it may be benign or it can be a problem. If there is variability, it may be considered benign, but you must consider the degree of the rate change and the duration, how long it lasts. It's considered ominous and a sign of non-reassuring fetal status if the heart rate is decreased with decreased variability and with late decelerations. With late decelerations, again, patient positioning, left lateral position on their left side is usually preferred. Hands and knees is another position that is important to try. Oxygen via face mask at 7 to 10 liters per minute, notifying your healthcare provider of the status immediately. We want to let mom and her support people know what's going on. We want to increase her IV fluids, stop the Pitocin, and definitely check vital signs. With mom, blood pressure checks, if for hypotension, we're going to treat per orders or protocol. Hypotension is a possible side effect of epidural anesthesia. We're going to assess cervical status at this point with these late decelerations to see if she's close to delivering. We want to prepare for an emergency cesarean birth and always document any interventions. Interventions for variable decelerations. Again, we're going to encourage position changes and get her to the position that relieves the pressure on the umbilical cord the best. We're going to still administer oxygen via face mask at 7 to 10 liters per minute. Let the healthcare provider know immediately what's going on and document this in the chart. Provide explanation to the woman and her support people. Prepare for a cesarean section. And be also prepared to administer an amnio infusion if there's not much fluid or oligohydramnios is present or if severe decelerations persist. For prolonged decelerations, we want to perform a vaginal exam to make sure there's not a prolapsed cord. The prolapsed cord is when it comes out before the presenting part and it may be compressed. We want to change positions of mom. Again, discontinue oxytocin if it's being administered. Notify your healthcare provider and provide explanation again to your mom and her support people. Increase IV fluids with the prolonged decelerations as well, and we may have to administer a tocolytic if we're having way too many contractions, which is tachysystole. Anticipate your physician or your healthcare provider anticipate a C-section if your deceleration continues or the fetal heart rate is previously abnormal. Be sure they are aware of all of this. Legal responsibilities, particularly to OB. Nurses caring for women during childbirth are legally responsible for correctly interpreting fetal heart rate patterns and for initiating appropriate nursing interventions based on those patterns and for documenting the outcomes of those interventions. So be very aware of your education level, and if you're working in this area, make sure you stay up to date on new evidence-based information. Nursing implication, we need to prioritize our patient, recognize encounters with the childbearing family as opportunities to provide education and empowerment. Again, let them make as many choices as possible. As trusting relationship through interpersonal interaction. Sometimes technology interferes with this because it's so easy to monitor from outside the room. We want to make sure that we're doing a lot of one-on-one nursing care. Make sure to fully explain the purpose of monitoring to your client before you use it. And always look at your patient when you're talking to them and not something else.